Good afternoon. A very big thanks from both of us for inviting us back to UW. I think our presentation at Eclipse was well received. Our very special thanks for making it go so well. And what we are trying to do today is go through the same presentation but with some updated information that you would like. Before I start, people ask me, how do you like Seattle? I say, fabulous. Feels like home, because at Michigan we have the same weather. The only thing we have to worry about is snow, not rain. So Ilan is a dear friend of mine. I am from your tribe, the lab tribe. Ilan comes from a foreign tribe, but he is a part of us now. My training is anatomical, clinical, molecular pathology with a year in informatics. And as was just mentioned, I did see the light during my residency, and I said, wow, if lab controls 70 to 80% of information that, or data that moves in the health system, why can't we at the center of it? Why can't we be the value engine that can convert this data into clinical value? And this 40-minute presentation or 50-minute presentation will be our quest, a joint quest between laboratories and its users, the providers, in creating this multi-part engine. So the first disclaimer that I'll start off with is, this is not a lab presentation. This is a presentation about a lab working with different parts of the health system.
My name's Ilan, and I'm not even a recovering trauma surgeon. I still am one. And we practice in the acute care model. And in fact, the SICU director at Harborview trained at Henry Ford. And we've actually sent some folks here for fellowships. We've sent folks from Henry Ford to become faculty here. And working at Henry Ford, first as a trauma surgeon and then more as an ICU director. I then got rolled up into our crazy Epic implementation, which was a 3-year ride. $350 million later, we really have something special, but wow, did it hurt coming in. And I think we're finally on the side of it where we can start to see where the good stuff happens. Some of it we can just see where it's going to happen as opposed to we're doing the good stuff. But we're having a good time with it. As I rolled off of that project, they were looking for an ACMO at the mothership hospital, which is where I practice. And as part of some of the other things that have been going on across our system, of which the EMR was one of them, was that we were increasingly doing system things, right? So the EMR was probably, and this isn't the best way to do it, but that was our first real system project. And what do I mean by that? It meant that all 4 hospitals, and now we're adding in a 5th, all 4 hospitals had to act like one, do things the same way, and do it on a very personal level on things that are high preference, right? Whenever you read about physician change management, they always say, oh, do stuff that's not high preference first. Well, the EMR is high preference, and we did it first, and we did it big, and you hit people where it hurts. How do I write my notes? How do I do my work? How do I order my labs? How do I order my films? And in surviving that, we laid down a structure and a framework by which we could actually do this kind of work, which was, and we'll go through the hierarchy and how it was all set up infrastructure-wise, but to actually have the system be able to accommodate this sort of work actually took some structure work up front, some planning, so that we could succeed. So we're an integrated system. We have a captive insurer. We have the mothership hospital, a 600-bed, 100-year-old hospital on West Grand Boulevard in actual Detroit, a city that until probably 5-10 years ago really had no hope of coming back and somehow is a comeback kid now. We have 3 other community hospitals that don't look like us at all. They tend to be in the 200 to 400 bed range. We just took on a 5th community hospital that's essentially the dominant hospital for an entire county. At the center of the main campus, but also one of the regional hospitals, is the Henry Ford Medical Group, which is 1,200 docs, plus another 600-700 residents and another 600 or 700 APPs. But the rest of the hospitals are all private. So that gets you what we're facing as we try to make clinical change is you've still got this mix. It's not all employed docs that we can just tell what to do. By the way, it doesn't work with the employed docs either. So Gaurav will give you a little background on what we are as a lab.
So the photograph here is our promotion photograph. This is summer in Michigan. I would encourage you to visit.
When it's not raining, that's summer in Michigan.
Pathology and lab medicine is a single department at Henry Ford. We perform 12 million plus tests. We are a group of 30 plus MD and PhD leadership, 700 employees serving the 4 hospitals as well as the medical centers. And we pride ourselves to be an ISO 15189 accredited laboratory, the only one in Michigan at this point of time. So why this is important is because we were already set up towards integration and standardization model because of our ISO journey. These are the objectives of this talk. Essentially, we are here to understand where labs fit in the current as well as the future healthcare model. How can we partner with EMR and analytics to get new opportunities? And most importantly, what is the governance mechanism? How do you agree to work? We all want to work, but what are the rules of the game and how to get to them? And finally, what we call the takeaway from this project, our pipeline. This is how we accept, process, and deliver on our projects. So, this is a nice article that came in 2010 when I joined my fellowship at Pittsburgh, and it was titled, "What is Value in Healthcare?" published in the New England Journal. And it's a very nice article about this very vaguely defined concept. Value, the author said, is something that is in the eyes of the customer. It is not what you and I perceive. So we may say labs are valuable, but it has maybe no meaning. What is its value in terms or in eyes of the customer, provider, patient, payer? That's important. And then it cannot be that vague either, because it has to be something that comes from results which lead to outcomes. This concept is very different to how value is understood outside healthcare.
So it's interesting because when you think about outside healthcare, and Michael Porter is actually considered one of the business strategy gurus, maybe one of the people that invented the concept of strategy in business. And when I say business, I mean specifically the rest of business, not healthcare. Because let's be clear, in the rest of business, when you say value, it's not even a coded term. Value means cheap, right? When we talk about Walmart and why they're so successful, we talk about value pricing, right? And it's a successful business model. There's billions of dollars in profits to stand for it. And it does provide a service, right? The customer is super happy. They know they can go in for everyday low pricing. Only in healthcare do we say value means the same quality, right? But Michael Porter's a very bright guy, and he actually, the article's very good, and he's actually written a couple of actual full-length books, if you have time to read them, about strategy in healthcare and why you do have to pursue this from the customer perspective and create that value. Again, it's still confusing because who's the customer? Is it the payer? Is it the ACO? Is it the patient? Ultimately, our duty is to the patient. It really, really is, yet we still have to keep the doors open. So it has to make sense financially. We have to pay the lights. We have to get the equipment in the door so that we can work, right? So there's always going to be this issue of margin and mission, et cetera, and making that all work. And value has to come without decreasing quality, again, only in healthcare.
So this is a nice equation that you can derive from this article. Essentially, the numerator is outcomes. And again, these are not lab outcomes only. These are outcomes for the end customer, provider, patient, so on and so forth. So if you have to increase your value or perceived value, you support clinical outcomes. And of course, cost, that is something that you can actually trace to the laboratory and say, what is the cost of sustaining an operation that can deliver a satisfactory or an above satisfactory level of outcomes? So whatever we present, judge us on the basis of this equation. Are we adding out, are we improving outcomes, or are we decreasing costs?
So ultimately, as laboratorians, I just learned that term and I hope I don't say it wrong or use it wrong, but we have to look at where we want to be in this new dance as it evolves. And the new dance is going to be very interesting because it's all about partnership, right? People want to pay one fee, right? When you know, I flew here on Delta. I pay one fee. The pilot doesn't get to charge me something different, and the stewards and stewardesses don't charge me something different for their services, right? I pay one fee, they get me here. And that's what all the payers want. Whether they're going to construct it in an ACO or a managed care environment or bundled purchasing, whatever new phrase we're going to use for it, people want you to keep the costs in check, keep the quality high. My payer friends tell me, quite honestly, they just want the costs down. They don't really know what quality is, and I have to tell you, nobody's really sure we know what quality is right now and what a real metric is for it. But so as we renegotiate all of these things, there's going to be one fee. You don't get to line up for your CPT code or your ICD-10 code or whatever it is that you're going to turn in. There's going to be one fee, and there's a whole bunch of docs and services involved, whether it's the lab, the OR, the radiology suite, the cath lab. Everybody's involved, and it's all going to get rolled up into one. And you can let the traditional folks be the king and queen of the ball, or you can get off of the side, stop being a wallflower, and show everybody how to dance. And the issue is that the tools for this dance are ones that the lab knows the most about. Lean production methodology, decreasing wasted work, decreasing errors, all of these sorts of things are things you've been doing for years. And in fact, we were lucky enough to watch your rounds today, and your residents know about utilization management. The internal medicine resident barely understands what utilization is. They just know that their admission got turned down. They aren't in the situation where every internal medicine resident has spent time trying to figure out what a good admission is. You guys are ahead. You should be running the dance.
So these are a few things that we as a profession agree describe us. This is what I feel good about. When I interact with clinicians, I often wonder, why are they asking for something that may or may not add value to care? But it's always confusing, because I choose to stay within the four walls of my lab. In reality, my clinician friends may be thinking about me in this manner.
So remember, the clinician is not a lab expert. The clinician uses a lab as part of many, many tools. And all they know is whatever tool they're using, it never seems to work. It never seems to do what they want. It never gives them the answer they asked for. It's never done in a timely way, and everybody always says no. So what's happening when you say no to the clinician isn't that a medical, factual, merit-based conversation about, is this lab really indicated in this situation? To the clinician, it's just one more in a litany of problems just trying to advocate for their patient from the bedside, even when you're completely right. So how does a clinician see themselves? Well, we've got a little bit of a God complex, right? And you know what? My internal medicine colleagues have gotten more and more invasive over the years. And I'll tell you that the average pulmonologist, invasive cardiac person, they've got a far advanced God complex to me. And I know these mics are live. We joke about it all the time, right? As some of the most incredible surgical complications in the hospital these days, if you're looking at patient safety indicators the way Medicare wants me to, are now invasive cardiologists, right? Or radiologists doing things that by CPT code are things that used to happen in an OR with an open procedure are now being done by other folks. So in this complex clinical world, people really think that they're the last bastion of hope for their patient. They're in this God complex. Every day is a journey. Every day is a day in the Lord of the Rings trilogy, you know, and this is adventuring on the road on behalf of my patient. And that frustrating moment when the lab says your quantity was insufficient, you know, a lot of stuff comes out in an ugly way. It shouldn't, but it does.
So what we think is the etiology of this relationship is because we, for all practical purposes, operate in operational, financial, logistical silos. So the lab is on the left side, the providers are on the right side. Just this arrangement puts us in a competitive mode where a no is seen not as an advice but as not getting along. And that actually comes from the fact that we are in this fee-for-service model where the existence for us is to receive an order, get a specimen, do something with it, produce a result that the provider needs to access and take care of his or her patient. These are the outcomes of this silo system. And this is not only lab versus clinicians. If you see any business unit or any two organizational and social units, as soon as they go apart and us versus them mentality crystallizes, all these precipitate. There are ineffective communication pathways. Should I call? Should I page? Should I leave a note? How do I do that? How do I understand whether they heard what I said? I know Dr. Dinitz gives us classes on communications in the OR. They are so important. When I said a frozen section, did they even get it? What did they understand? How can I even be sure that the patient was the same patient that I was talking about? Because I have chosen myself to be in a silo in a frozen section room compared to the OR. Hard to navigate systems, EMRs including reactive problem solving. We all have a lot of work to do, and when something goes wrong, then we don't want to do a proper root cause analysis because there isn't a lot of time for each time that happens. We want to just take care of it and move forward. And ultimately, it leads to lack of trust between the two silos. And what we need now is some sort of an alignment rather than this silo mentality, and alignment. Because we are going to be judged as a team, not as individual players. And this is the reason why.
So without being very far down the route of value-based payments, we already as a system are facing greater than $50 million at risk for next year on value type kinds of calculations. And we know that that's going to go through the roof. So as we talk about these value calculations, it's a really important thing to keep in mind is there's a lot more partners that want to do the dance with you now because everybody's got this stuff coming at them, right? Inpatient, outpatient, you know, every kind of specialty is all facing risk related to quality. We're in a funny environment where Blue Cross is the dominant non-CMS payer in our state, and they essentially have run all these things through quality collaboratives. And if you don't pay, if you don't play, you don't get paid in their quality collaboratives. We're signed up for every single one of them. And by the way, you do get some data back. By the way, it does help you work on some of your quality projects and utilization projects. But this is where it's going. We know there's a lot of money at stake. And now, because of that, that means there's a lot more partners looking to collaborate, looking to improve on all these things. And remember, you can work on the cost side, but you can also work on the quality side. And when you're really hitting your stride, you're doing both at the same time.
Okay. So people say, why don't we decrease costs? Because that's what we can control. I submit to you that in the $1 of healthcare spending, labs only account for 3 cents. We may be the center or the origin of 70% of lab data, but on the ledgers, we don't count more than 3 cents. So even if you become 50% more efficient, you will just move the cost from 3 cents to 1.5 cents, and that won't move the needle. What we need to think about is what do we impact rather than what do we control. So one of the things why, or one of the reasons why labs are being targeted with reduced reduction is because the payers understand that overutilization of labs leads to overutilization of other services. So it has been estimated that anywhere between 15 to 40% of healthcare waste can be attributed to excessive diagnostic procedures, including the lab. That is why they are reducing the reimbursement. So on the flip side, if we do impact so much of the clinical activity and outcome, then why shouldn't we focus our efforts towards that and find new avenues? So these are certain examples where lab testing actually directly impacts reportable hospital quality metrics, and payment is adjusted to these.
So if you get your STAR report or you get your CMS value-based purchasing report for whether it's Harborview or here at the University Hospital, you'll actually see these kinds of metrics on there. And this isn't all of them, but clearly this is a big percentage where there's labs in play. Labs part of what makes up the hospital's report card.
And then there is this big push from almost all medical specialties about choosing wisely. And a significant proportion of choosing wisely is related to lab testing. So again, the game or the ball is being played in choosing wisely. We make a choice whether we sit on the side and wait for the right choosing wisely order to come, or we come onto the stage and say, let us help you choose the right test. Another fact is this: in this value world, the value chain, which is you start somewhere, you do something with it, and you end somewhere, has to be very well understood. In a fee-for-service model, our value chain was getting an order, doing something with it, and producing a result. But in a value-based payment model, I would submit that the diagnostic process actually begins far more earlier. For example, what is the right order set? Is it on the menu? What do the clinicians say about it? What are the guidelines? So on and so forth. So the diagnostic process that we claim our expertise in is not within the lab. It's actually on the floor or in the clinic. And then we get the result and we send it back. Again, the interpretation part of our diagnostic result is also a part of the diagnostic process. And our data at Henry Ford says that 92% of defects that we see in relation to diagnostic lab testing are before even the specimen showed up. Wrong test ordered, wrong order set selected, wrong handling of the specimen, so on and so forth. And 5% were related to the post-analytic step. So we are already the lean leaders of our organizations, and that reflects that our waste is at 3%. Our opportunity is here in the pre-analytic step, outside the lab, rather than in the analytic step, which is within the lab. But going outside the lab is not easy, because if you try to do utilization control by yourself or work with clinics in reducing their defects and adopt more of a patriarchal approach, there is always dissatisfaction. And these are the reasons, and this is the feedback that you get. What we need is some sort of a collaborative and a very transparent framework on how to go about and engage with clinicians. And most institutions don't have it because of the silo system that has prevailed for decades. So what we wanted to do was get out of the box, but with a system and a manner that ensured that we don't get into trouble. So this is the future state.
So in a future state, you've got data that is, of course, this is the informatics quest, right? Is instead of just data, you have information, you have insights, you have knowledge creation. And we wanted to create a system where we are bringing each other together, and instead of being silos, we're actually trying to deliver on these goals in a shared way. So we had to align the goals, we had to establish governance, and I can't emphasize that enough. It's all about the governance and the structure. And I'll tell you, nobody wants that less than a surgeon, but that is how you have to do these things. You have to plan for it to be successful. You can't get 4 hospitals to work together unless there's an infrastructure to settle the scores, to end the ties, to make the decisions. And we were able to establish that. That's us on our quest to establish the infrastructure. I'm a little thinner in that one. Thank you for photoshopping me.
So before starting any project, the leader or the leaders have to sit down and think about why are they doing something before you think about what are you going to do and how are you going to do it and when will you do it. And this is how we approached it. We knew that we had to get people involved, and we knew that if we had to be effective, then the intervention had to take place through the EMR, that is technology, and then we had to come up with a process to coordinate all this. And it looks very easy till you dive into each one of them, because you have to figure out how do you organize people, how do you get people from technology and understand the limitations of technology, and what is the right process, because you are starting with 0 process. So before we started, we agreed that this won't be a lab project, this won't be a system project, this won't be a provider project. It will be a lab/provider project at the system level. We defined roles and relationships, came up with goals and missions, and we said we are going to go after what is really needed in terms of knowledge and cost effectiveness.
So we wanted to be multidisciplinary and collaborative, relevant, and evidence-based. And we also wanted our team to be kind of self-learning. So we kind of would bite off projects of an increasing scale and complexity.
So this is very important, which is before you start new thing, go and get a license. And the way we got our license to do all this was we went to the Multidisciplinary Provider Council. This is the apex council of all providers and non-providers and the administration. And we asked for them to start what is called a medical lab formulary committee. So just
put that in context. So we were a non-system. We had Henry Ford labels on a lot of hospitals, and we didn't act like a system. We had different formularies for meds and labs. We had different labs. Everything was different, right? And this was, again, one of the things that happened with Epic was, well, you can't do that. You had to have one pharmacy formulary. You had to have one lab formulary. We were doing one instance of Epic for 4 hospitals. We had to force ourselves through this conversation. Sadly, it puts a lot of pressure on your EMR to have that be your first system project, but it's so all-encompassing when you do your EMR transition that it's not the worst choice either, because you have to make really critical things like nursing policy changes. You have to make policy changes related to every kind of clinical care as you implement an EMR. So it kind of was a great opportunity, although it made the EMR transition more risky in itself. As part of that creation of a system infrastructure, we set up these system councils. And they actually started as EMR councils. So councils related to policies for the EMR that had representation from the 4 business units. One of them was this lab formulary committee. Okay, so a system council, representation from all the business units. We have a surgery one, we have a medicine one, we have an ICU one, emergency medicine. We had a lab one. By the way, there's also a pharmacy. Pharmacy had a little different structure. They went with a pharmacy formulary committee at the system level and a separate medication management committee at the system level. But again, a similar concept. This was done as system structure, representation from all the business units, reporting to what in our system was the pinnacle of clinical decision making, which was sometimes referred to as a CMO/CNO forum, otherwise called the Multidisciplinary Provider Council. And that could settle all the ties and make all the final decisions. Yes, there's an MEC that's separate at each hospital, but when you're thinking about making these tough changes, and again, the deal is you want to pre-syndicate every change so you never have to use authority and rights and rules to get anything done. But having the structure, having the big gun available was really, really important. And having a body that could channel all of the decision making of all the smaller hospital committees was super important. So that's our Multidisciplinary Provider Council. It's named different things at different systems, but that's how that served us.
So within this, we had two subcommittees. One committee called CTAC was pathology internal, and we looked at send-out tests. For 1 year, we did this, and it worked very fine. And they gave us the authority to form what we call LUTF, Lab Utilization Task Force, which is this talk, which was provider-led. So yes, it's a lab-related project, but I'm a minority of one on that committee. The other 21 members are non-pathologists, non-laboratorians.
And they're a mix of clinicians. We'll get into the membership.
So the next thing we did was we said having meetings never works. Meeting for a meeting is not working at a meeting. It doesn't work that way. We have to have a steering committee that can keep a track of what's going on, assign tasks, and have some accountability. So Dr. Rubinfeld, myself, were the physician leads for this subcommittee, and we got one project manager from our system performance improvement and a medical technologist from the lab. And all we did was bring different skill sets. My addition was bring in pathology's perspective into each and every project request, and the medical technologists that came from pathology brought in project management for the lab. So once a decision had been taken, how do you operationalize in the lab? That was her job. And then our project manager looked at the system level perspective and said, what you are discussing here has been discussed somewhere else. Can I connect you with the people there? And then Ilan brought in his spectrum of skills, which was...
So this was where having the EMR background was very helpful, and connections to the analytics teams, which we have. Everybody structures their analytics a little differently. Ours is separate from IT and also, interestingly, separate from the EMR, but they all work together. But also, I happen to serve on that Multidisciplinary Provider Council, as well as some of the lower councils. So it was also easy for me to then get things onto agendas and present them to friends rather than strangers.
So our advice to you would be, if you are doing any utilization project and it has more than 5 members, form a steering committee, because more than 5, the things will never get done. Okay, so this is what the traditional view of partnership for labs is, which is we want to change something, we are the lab, we know what to change. Our providers are our suppliers and our customers, so we'll go to them and we will educate them, convince them, collaborate with them, and ultimately this will benefit the patient. And I would submit this is a very incomplete view, because if you really want to change practice, not only behavior, if you want to really change practice and sustain that practice, these are the missing elements. Any change in practice has to be authorized, vetted, and sanctioned by medical leadership. So if you don't have, as a lab, direct connection to the system leadership, hospital administration, things won't go very far. We also realized that once a change had been made in an order set or something like that, we had to go through a very rigorous change control process in the EMR, for which the lab had no idea how it worked. We had to actually justify return on investment, and the only way we could do that was to get finance people on board.
You need creative finance people. So, and this is, so we as clinicians understand that there's a lot of other ways to benefit a patient or a system, and a traditional finance person, or if they just send you an analyst, will not be able to help you, right? The analyst will run a report in a traditional way, and the only thing then available to you is an incremental cost or a charge related to a lab that you avoid. What if you want to say that something leads to less sticks? How do you value that? You have to have a finance person that's high enough up in leadership that they're allowed to be creative and value other things that they know benefit the system in terms of customer happiness, right? Because that's another metric that's measured. It's not happiness, it's customer experience, and it's done by Press Ganey typically. You outsource it to somebody to survey our patients endlessly with 18-page surveys, and then you're surprised that they don't return them, right? We're all doing it, right? And we're stuck with that. But you need a finance person that sees the whole spectrum of that to understand that the value, this project may not pay for itself by incremental decrease in a few hours of one tech or the variable cost related to 1,000 of this, right? This project may pay for itself in many other ways, and you need someone creative to be able to talk to you in that way.
So then we had to actually define the process, and this is what I think is unique with us, and this is what we are sort of trying to propagate. We said we will not make any changes if someone higher in the authority comes and says, make this change. We will have a defined project intake funnel that would be run by the steering committee. And that will actually go out and seek input from different stakeholders. If there is a new guideline comes in, labs won't jump on changing practice. We'll move it through this intake funnel. If there is something from choosing wisely, we'll move it through this. So we actually wrote procedures to make this evaluation objective. Not every great sounding project is a successful project. Raise your hands if you believe that, right? Somebody comes and says, this will change patient care. No, it doesn't, because there are so many variables that no one thought about. And this step actually allowed us to do that. We would review the feasibility of making the change by running it through the finance people, operations people, get an expert from the clinical specialty to do an evidence-based check, because one clinician may come and say, oh, this is the national guideline, start yesterday. When you do a literature search, there was one abstract that was presented at a national meeting. That's the only evidence. So we actually use, for example, if someone came from cardiology, we had it cross-reference from someone in cardiology. We did some pilot data checks, and we actually said, okay, even if we build it, will it work? So some sort of usability checking. After this, we would then move it to the analytics group to run a pilot.
So, and this could take different forms. Often it's just a matter of we track a certain metric. And actually, this has probably been the most building for your future kind of piece here, is that as you develop the analytics capability to take on one and then the next project and the next project, you start forming kind of a list of utilization metrics that you can follow and then you can hand off, right? So each of these projects, you start by kind of truth testing with analytics. Does there look like there's something here? If I make a small change, can I affect a metric? Do I even like this metric? Does this metric mean anything? And you kind of commit based on, as you formalize the project, maybe this is going to be an iterative problem that I'm solving forever. Like I'd argue that's what daily labs is for us. You know, what is enough labs to get me safely through an admission? I think we're starting to refine our answer to that question, but it's probably one of those things we're going to do for a long, long time.
And finally, if the pilot is successful, then we would take it to governance, because you don't want to go to governance unless you have done your homework. They want to believe what you say, and the only way they believe you is by having credibility. And to have credibility, you have to come with data and come and provide evidence of there has been due diligence before it demands their time. So if everything looked fine, there was no patient harm, there was demonstration of value, then the governance would give a go-ahead for all 4 hospitals at the same time. So then if there were naysayers at the end, or if there was resistance, you did not fight individual battles. You would go back and refer to the governance decision. This is how the process looks now. It starts with an idea, goes to the steering group, gets a pilot, gets a governance look over, leads to adoption, and leads to a conclusion, or a feedback to, again, a new idea, for example, for daily labs. What I want to emphasize for my lab colleagues here is this, that any change process utilization effort regarding a lab test will only need our input and active involvement in the first half. Just by the very nature of the healthcare system we operate in, our span of control is this. After this, the span of control actually moves into people who are responsible for EMRs, analytics, and the provider groups, the governance part. And this is very important. And what happens most of the time is that if you try to go through this process and it gets stuck here, we believe that our effort got wasted. All that happened was we did not pass the baton at the right time. So we're going to share a few examples in the next 10 minutes or so. This is state of Missouri, show me. So we have talked about a lot of concepts and challenges and our solutions. Does it actually work? So I'll start with the idea of troponins. Do we do too many of them, and are the patients waiting for troponins that add no value to them? The classical example is a person who has come in with chest discomfort, has limited clinical signs or symptoms, EKG readings, and two negative troponins. Is there a value to doing 4th, 5th, 6th, 7th troponins or not? The literature says there isn't. But when the labs went back to the providers and said, let's curtail the use, the answer was no, because this is too risky. And I think if I was a provider, I would give the same answer. Why do you put me in a liability situation?
Number one lawsuit cause for an ED provider, chest pain is number one, belly pain number two. So your radiologist colleagues are all pissed about how many extra CAT scans I get for the bellies. And on the cardiology side, the acute MI workups, everybody gets way too many of everything, right? Too many echoes, too many EKGs, because they're worried about the lawsuit.
So in the traditional sense, if we operated in silos, we would say they are not doing a great job. They would say we are trying to interfere in their clinical practice. And both sides are true. What we did was we just put this in the pipeline and we said just run some analytics. And when we ran the analytics, something strange popped up. So these four bar graphs represent the 4 hospitals of Henry Ford. Can someone tell me where is the highest utilization?
Where's the 600-bed hospital with an inner city emergency room in the most hostile county, one of the most hostile counties for malpractice? It's 100,000 patient a year visit ER, right? Which one is that? It's not the one I thought it was. I thought it was number 2. It's not. That actually is a suburban hospital. The ED group is a private contracted ED group. They had Cerner and converted to Epic, so they had all sorts of habits and practices in their Cerner practice that they were kind of messing with Epic in order to accommodate how they used to do things. It's a fabulous example of, you know, go do honest inquiry and you will find all sorts of truths you did not expect, right? So it was not the academic center that had the problem. It was one of the private shops.
So just giving this data did not add any value, because how do you fix it? So we went back to the ED providers and we did what labs have done for decades, which is educate them. They did get their education, but there was no change in the ordering pattern. So we actually transferred this to the EMR analytics team in our pipeline and said, there seems to be a problem. Is there something that we have something wrong in our EMR? And the answer was yes. Actually, the order sets at HF2 hospital had been built in a way that they would trigger these repeated troponins. So this is a classical case where the lab is trying to do the right thing, the providers are trying to do the right thing, but the problem is not between them or within them, the problem is within the order set, and that is systematically propagating overutilization. And we could only discover this because we were not looking at these problems in silos, we were looking at it in a group.
Yeah, and to be clear, these phases are all happening simultaneously, because when the committee meets, we've actually got the EMR people there with us, the analytics people there with us, and so we're asking all these questions all at the same time.
Right. And then there was, let's go back. There was this question about what is the evidence in our health system that a third or more troponins is really needed? We did a chart review of 100 or so patients which got a third or more troponin and found that only in one sort of not very clear case there was an added value of doing a third troponin.
So that's of the 100 third troponins that were actually positive, only one of them didn't have clear clinical signs that they were going to be positive, right? Because nobody's arguing about doing a third troponin in somebody who has new sudden onset horrible chest pain while you're staring at them. Right? That's not the argument. That's not a choosing wisely, right? Somebody whose clinical status has changed, that's a free ride. You're allowed to order that test, right? And that's also one of our challenges, is to make sure that we don't lower the boom so hard that a good clinical call is now no longer allowed, right? But we found one good clinical call in the 100. So that got presented at Society of General Internal Medicine.
So this was the change process. It went through and we were able to get the order set free. And this was the change in the ordering of this test. As you can see, in the month of June of 14, we had 500 or so orders of third or more troponins, and it started to drop. The intervention was somewhere here. So there is some education here, and then there is some, the rest of it is actually fixing the order set. So once you fix the order set, the utilization automatically drops.
So the other thing that's important here is then at that point, we stopped owning it. And we found a clinical owner that is the more appropriate to say, okay, now I'm going to make my stand and I'm going to keep improving on this. And what that was the newly founded Emergency Medicine Council. So then you have a system council that now has a utilization metric that they can track, and the leader of that council is highly passionate about efficient and excellent chest pain workups and loved it, and so he's going to drive the next round of improvements on this metric, so, which I think is an important place for us to be, is we don't have to own these for the rest of our careers. We can hand them off to the clinical owner who can then drive the next level of improvement.
So one thing that we realized was, while we touted this as an efficiency improvement in the lab and reduction in troponin tests, actually the real outcome and real value in this was how it impacted patient wait times in the ED. We went back into the EMR and we did analytic pull to figure out, compared to earlier, how many patients were able to cycle through the ED faster. And it turns out that by this change, we had north of 5,000 ED wait hours for patients saved across the system, just by making one change.
That's why you got to have a real CFO or some system thinking finance officer at your meeting, because they can understand why a quicker turnaround in OBS is money, right? Because if you say, I avoided 10,000 troponins, that's not actually that much money. I know it seems horrifying that people wouldn't get excited about saving 10,000 troponins, but it probably doesn't pay for this meeting, right? You're probably also lean. If we added up your billing rate per hour, which, you know, I know you're academics and you work for free, but even if we added that all up, we didn't pay for the meeting on 10,000 troponins. But once you start saying, okay, your OBS beds will be more available and more efficient. Remember, the modern hospital is ICU, OBS, and just a couple of GPU beds while you're teeing up somebody for home, right? That's where your growth is and where your business is. It's all being driven into OBS and into your ICUs, and there's very little in between.
Mm-hmm. So we took the same stab at choosing wisely recommendations, and one of the ones that we wanted to pursue was daily labs, which is don't order tests that are really not needed during an inpatient stay. So it went through this process. Everyone agreed or disagreed, and if there was disagreement, ultimately they agreed. And we were allowed to make a change in our protocol in Epic. And what we did was,
So the issue was, and we actually discussed this prior to our Epic Go Live, and because before you do it, everybody's so freaked out about what's going to happen, this was an important safety thing we couldn't do. And it was perceived safety. It wasn't real safety, right? But before the Go Live, we couldn't make this change. And that is that when you order the lab and you say, okay, I want a CBC and lights tomorrow morning, you could actually say, I want it daily. And that's the problem, is you just can't have that option out there because it'll get chosen. This way the resident, the intern, the mid-level, whoever it is taking care of the patient, well, this way I won't forget, right? Because the worst thing you could possibly do is not lab somebody every day, right? That's, it's malpractice, right? So once we went through, and to just give you a version of the journey on that one, was we actually had to go to all of these practice councils, right? We had to start at the Multidisciplinary Provider Council. We then went to the GPU Council, the ICU Council, Nursing Council, all sorts of folks. We had to go to the high preference folks that we knew would freak out, NICU, bone marrow transplant, those kind of folks, and actually work with all those folks and explain to them what was going on. And the other interesting thing was the anti-coag team from pharmacy really needed daily PT-INRs in order for their workflow to work efficiently. So we had a couple of exceptions, cyclosporin A, FK506, and the PT-INR. And oh, by the way, in Epic, you can't limit it. If I said that, let pharmacy have a CBCQ day, no. You can't limit it. If I give it to one provider, I give it to everybody across the entire system. And by the way, our analytics team showed us that essentially had become the default way to admit your patient, is with daily labs ordered on a whole bunch of stuff. And it was incredible. So when we went through the whole approval process, we then said, okay, let's make the technical change and see what the technical success can be. So as good as that graph goes, let's be clear, this is just the technical success, that we were no longer ordering daily labs. And you could say, well, it's not zero, and you're right, because we still had the FK506 and the cyclosporins. But then there was another funny thing, is we had urine methotrexate, and we still had the PT-INR, even though at some point we got pharmacy to say, we don't need this, because some of our Epic build teams showed them a way to see all the PT-INRs, and they wouldn't have to order them default, right? So we actually, even though this is a technical success, we could do better. And it's going through in the next upgrade. We're losing the ability to order daily urine methotrexates and PT-INRs, so that'll get better. But then, and this is another way to look at the same data, which is here you can see CBC with diff. The only reason some of those are still getting ordered daily, you have a 1 and a 2, those patients were still in the hospital that week. Okay.
But from a daily or a weekly count of 700 and 600 CBC diffs, everything disappeared after this.
Yeah.
Same thing with creatinine.
Just a technical success doesn't mean they didn't get a CBC every day. So how do we ask that more difficult question? And that's where we're still iterating on what's the right report. Because it's okay to get a CBC on day of admission, right? I mean, depending on what we're admitting you for these days, to justify an admission, you got to be pretty sick. So what is our opportunity on utilization? Is it 100%? Is it 10%? We don't know, and that's actually going to be a very difficult thing to look at. We do have some data from a company called iVantage that does benchmarking on your expenses, and maybe some of you have been getting data from groups like that benchmarks your spend. And we actually look really lean, where we're, 22 labs per discharge, right? So if we're already really lean, what's this daily labs thing going to do for us? So one of the things we wanted to look at is, so this is, we don't have the other way of looking at it. So one thing we were doing is labs per discharge, but the admission day wasn't at risk, right? Because you're still ordering. You're going to order stuff on admission. So this is a different way to do it. We said, okay, free ride on everything you order on admission. Can we make a difference on everything after admission because you can't order it automatic? And this graph is showing that. So this is kind of a second generation look at labs per discharge on days not of admission. And it shows that essentially of the opportunity that we had, we're making a difference. This shows a 10% difference. And you know, we think that there's more room to tune it up, and some of it is increasingly more sophisticated analytics to see what your opportunity actually is, and then going back to seeing what your gaps are, and developing it further that way.
So in the labs, not only is the change difficult to make, I would submit to you, even if you have made the right change, getting the right metric to mean the right value is a more difficult task. And this is the first time that we came across it, and as you do more and more utilization projects, you will come across these too. I just wanted to highlight one quick thing. We also had liver profile on a daily ordering queue. I have a resident who's working on it. Why were we ordering 87 liver profiles on a daily level?
We had over 140 labs. So this came through the EPIC Foundation. Over 140 labs had the option to be ordered daily.
Mm-hmm. Then going through this workflow and working through this pipeline, we also discovered some other defects. For example, tests that have been mislabeled. For example, this represents vitamin B12 binding capacity, 125 dihydroxyvitamin D. I have done genetics. I recall a term called chimera or mosaic, right? Two entities fused together. This is like a chimeric mosaic lab order. So of course, as we dwelled into it, we found more and more such defective labels, and we got them fixed. The other thing we noticed was that the name of the test actually is not very informative, such as vitamin D. What does that mean? There is no clinical decision support, if I may say, in that name. So what we are trying to do in the next iteration is, can we just say vitamin D not useful for screening, or vitamin 125 dihydroxy to be used only by designated subspecialists? It's an experiment. It's ongoing. We'll come back with results.
Yeah, and so that actually got approved for build. It's going in next week. So actually the title of the lab will be "Don't Order This," essentially, right?
So another thing that we are trying to do, and my special thanks to Patrick and Brian for inviting us to the Eclipse meeting. This is an idea that was presented there, which is to benchmark. And we are in the gathering stage. So we want to see how many dihydroxys are we ordering for hydroxys. And within hospitals, because the hospitals and medical centers are of different size, you can't just do a pull on number of vitamin D's order. You have to have some normalization. So the idea that we are going to get inspired from is to normalize it from CBC. If it's a big hospital, more CBCs. If it's a smaller hospital, fewer CBCs. And we want to look for those results.
And this is actually more of an ambulatory thing, and we actually have our primary care network has already done a project trying to decrease their vitamin D orders. And so we actually, they had one of these metrics already worked out. We didn't have time to add the slide in. We just got it last night. But they've already started working on this, and I think it brings up, you know, how much opportunity there is. So the way they're looking at it is labs, vitamin D labs per day in the system, right? And they brought it from somewhere like 180 down to 140, 150. Probably if I poll the people in this room, and again, I know there's really not enough information in that. Is that for a whole state? Is that for, it's just for the catchment area of our lab, right? And I don't know how many lives are covered in that, but who knows if 20 is the right number, right? So it was a 10, 20% reduction, but probably who knows if 10% of it's valid, right? And that's the thing is all of these utilization and quality projects are all iterative. Primary care is super pleased. They did some sort of performance project, got a whole bunch of funding related to it, and it was a great success. And yet, as soon as we saw the numbers, we realized, wow, we could probably take it down to a fraction of that with the right interventions.
And somehow just labeling the test in a certain way might help. That's my guess, but we'll see. So we are working towards provider scorecards. This will be a long-term project, but it has gone through the pipeline and we are extracting data on it. What we want to use is third-party analytics.
I just want to, there's two ways that we're looking at this. So in complex settings, it's a little harder because who owns a patient on what day, right? It's with complex teams. So there's going to be a more sophisticated version. But right now, remember you send out a bill, and the bill has a summary of the lab charges. And I know that charges are kind of a funny construct anyways. But if, and we've actually got this already out on our analytics website, we can tell you the lab charges and adjust per DRG and give a report card to each internist or surgeon or whatever and put them on a funnel plot and show who utilizes more and who utilizes yet less. And we built that for all the utilization buckets, right? Because radiology, cardiac diagnostics, et cetera, pharmacy, these are all very big buckets of utilization. But we haven't started a project of actually forcing docs to look at it. We already have our first volunteers. Our hospitalist team at the Detroit campus is excited to dive in. But that's some really powerful stuff. For this DRG, for the sickness of your patient, you used more or less lab services than your colleagues. That's a very powerful conversation.
So this is the Stanson BPA that we have signed up for, and what it allows us is to have alerts triggered in the EMR whenever a certain criteria is met or not met. All we intend to do is use this BPA monitoring system to track which are the problematic issues that we can address and which are the ones that are not worth pursuing. So if it's triggering thousands of BPAs, then there's something wrong systematically and let's fix it. If it's just 5, even though it's the best thing to do, we will just ignore it for the time being. This is how it is used in blood utilization, and you can see do not transfuse if the hemoglobin is more than 7. This graph shows that the BPA was being triggered a lot more compared to the succeeding months. Oh, okay.
So this was it running in silent, where it would have triggered this often, and as soon as we turned it live, you can see a drop. And then the other thing that you look at with these things is not just the follow rate, because you could argue if you've been doing a good job of teaching people blood component utilization, that when they're ordering it and the hemoglobin hasn't been documented to be less than 7, that they might have a good reason, right? So follow rates can be a naive way to look at these alerts. So the override reason is also a fascinating thing to look at. And then when you start to see, in our case, we saw a high utilizer, high overrider team was the cardiac surgeons, who actually in their quality collaboratives have their transfusions analyzed under a microscope. We're in pretty good shape. If our worst abusers are people who have a long history of bringing way down their blood utilization and are treating active bleeding, right?
So this is the slide from earlier. We think that with this utilization framework or the process that we have devised, we are able to meet these elements. And that's very important if labs have to have a play or a role in the ball that is being played. These are certain things that go into making sure that this is collaborative and something that is mutually respectable between departments, which is have face-to-face interaction, take this as a team, ask for accountability, be willing to fail, because most of these projects are clunky in the beginning. There are a lot of failures, there are a lot of naysayers, but ultimately you succeed. Meeting hygiene, very important, something that I learned from Ilan.
We've gone way over, so we violated all the meeting hygiene things.
So essentially, what we want to communicate to you is this, that if labs want to do active utilization management, have clear authority, have joint ownership, triage projects, not everything can be fixed, and ultimately have a well-defined process. We feel that labs are centrally situated in the healthcare system. There is a lot more opportunity rather than threat in the value-based healthcare system. And it is our inherent capabilities in handling large information and data sets that sets us apart from other clinical departments. The challenges.
So you got to get off the wall. You got to get out into the dance. You got to have your clinical partners. You can be very successful. They're looking to you for help. They haven't been on this journey as you have. They don't understand utilization. And in the case of labs, we don't even understand that there's an entire expertise of understanding labs. The average clinician has no idea what you do and the value you bring. And unless you get off of the wall and into the dance, it's not going to change.
Right. And the only way we will find our place in the ball is by having this structured process and making this collaborative. And finally, not making ourselves better, but making the clinical outcomes better. That is the truest identity of value for labs. So with that, let me thank all of you for your attention.
And apologies for going over. Thank you.